So I'm going to go ahead and get started. So I thought it would be useful to sort of compare and contrast what diagnosing a different type of illness is, what that experience is like for both patient and provider, and then compare and contrast it to fibromyalgia and why it can be so muddled and messy and why it can take so long to achieve the correct diagnosis. And you know, part of this is because the way Western medicine, conventional medicine is set up is we really focus on laboratory findings or radiologic or imaging findings to diagnose illnesses. So if you think about somebody with diabetes, they come into their doctor, they might say, I've been urinating a lot. And that's a common kind of first indicator of diabetes because you're excreting glucose in your urine, so more water is going out. So then a doctor is like, aha, I recognize that symptom. I know exactly the lab test to do. I'm either going to order hemoglobin A1C or have people do a glucose fasting tolerance test. And then if that's abnormal, diabetes. Very simple, really. Like it can be diagnosed in one or two office visits. And then the treatment is also very, I wouldn't say simple. There's a lot of different ways to treat diabetes, but it's very obvious what you're treating, right? High blood sugar, we're trying to get it lower. And there's lots of different ways to do that, different pills, insulin, injections, but very clear and very kind of focused on just that piece, right? So diabetes, simple to diagnose. Management is more challenging, but very easy to diagnose. And then kind of closer to the fibromyalgia world, I was thinking that rheumatoid arthritis is probably a good thing to compare what somebody with rheumatoid arthritis, what their experience of being diagnosed is compared to somebody with fibromyalgia. So for those of you that don't know, rheumatoid arthritis is an inflammatory autoimmune arthritis that affects particular joints in the body, particularly like wrists, ankles, toes, some of the hand joints. So there's sort of very specific areas that rheumatoid arthritis affects. So, for example, I've diagnosed rheumatoid arthritis back when I was working more in a rheumatologic setting. And it was a young woman who came in because her feet were hurting a lot. And she thought maybe she had like plantar fasciitis or her shoes weren't fitting. But then as I spoke with her, she was like, these joints here, they get really inflamed and tender and they're red and hot. And then I looked at her feet and the actual kind of knuckles where the toes meet her feet, and her ankles were kind of swollen and red and inflamed. And I was like, this kind of looks like rheumatoid arthritis. So I order a blood test. I look for the rheumatoid factor, and then there's a different test, the anti-CCP antibody test. Those are both looking at kind of the immune system activation in that illness. And within 3 days, I have the lab results back. Boom, diagnosis of rheumatoid arthritis. Get her to the right person because I don't specialize in treating that. And then, off she goes with very targeted treatments, right? So think about how different that experience is for both patient and provider compared to somebody with fibromyalgia who comes in and maybe is even having a hard time like recognizing themselves. Like for me, when I was dealing with the symptoms of fibromyalgia, I remember talking about how my neck hurt and the front of my neck and then my upper back, and then I was really tired and I wasn't sleeping well, and I kind of had these like a laundry list of symptoms. And I recall my primary care doctor sort of just getting this like glazed look, like I have no idea what could cause that constellation of symptoms. She ultimately sent me to a rheumatologist who was very helpful and said, I think you're just depressed and stressed because you're in medical school, blah, blah, blah. Fast forward 18 months later, it's finally a chiropractor who says, I think you have fibromyalgia. And I was like, what? Like my primary care doctor had not suggested it. The rheumatologist I saw had not mentioned it. Of course, this was a while ago. It's about 24 years ago. But I had to see multiple different providers. I mean, I think I saw at least 3 different MD specialists. I saw an acupuncturist, 2 different naturopaths, and 2 chiropractors actually. And it took all of that before I was finally given the suggestion by a chiropractor that maybe this was fibromyalgia. So that's a very different experience. And the difference is a few things. One, the symptoms of fibromyalgia can be subjective, right? We're describing what our experience is of pain. And one patient might describe it as, it feels like I have fire down my legs. Another person might describe like the neck and the upper back pain. Somebody else might really have more issues with the fibro fog. That's what's going on. Hi there. It's good to see you guys. Hello, Nova Scotia. And Anne, I see you. So like that's a very different experience as opposed to like these knuckles hurt and are inflamed. So there's variability in patient experience. There's variability in provider comfort, how often they've seen somebody that has that constellation of symptoms. And then here's the kicker. There's no diagnostic test. There's nothing that's like, hey, let me check this blood test that will say, yes, you have fibromyalgia or no. And towards the end, I'll explain kind of how we're moving towards that, but that up until now really is still the same case. Like we don't have that distinct yes or no, you have fibromyalgia or not. There's not an imaging test. There's not an accepted lab test. And so it becomes a diagnosis of exclusion. And what that means is you have to rule out anything else that could be causing those symptoms. And there's about 10 different illnesses that could be causing those symptoms that a doctor has to work up. So it's a complicated, time-consuming process that if you don't know exactly what fibromyalgia is going to make it really, really hard. And this is why there's been so much confusion. I would say this is part of where the stigma and the kind of negative relationship that some doctors have had with the diagnosis of fibromyalgia. I think that's part of where it comes from, is it's just not clear cut, right? Like rheumatoid arthritis, diabetes, black and white. Have it, you don't. Fibromyalgia, we're more in the gray zone. And so a doctor really has to know what they're doing to be able to identify it and think, aha, I should look for fibromyalgia, and then know what to do to diagnose it. So that's kind of where we have been. And I think this is part of why it takes so long for fibromyalgia patients to get diagnosed. And that's why I did the survey, because I was just kind of curious to see how long in general it took people that follow me on Facebook, how long it took them to get diagnosed. So I'll tell you those results in a second. But I wanted to talk about, there's been two different pretty large surveys of patients asking them how long it took them to be diagnosed. And these were well done. They were published in, medical journals. The first was from 2000. So that's about the timeline where I was being diagnosed and dealing with symptoms. At that point, on average, it took a patient about 5 years from start of symptoms to be diagnosed. And they, on average, saw between 7 and 10 providers, it doesn't specify what providers, before they got their diagnosis. I mean, what an absolute nightmare for somebody dealing with fibromyalgia symptoms to go through, and trying to navigate the healthcare system and keep advocating for themselves and keep pushing and keep having to have a negative experience with a provider. I mean, it just is heartbreaking, honestly. The good news is things have improved. So in 2010, so 10 years later, a very similar study was done. And at that point, the diagnosis of fibromyalgia took somewhere around 2 years. So 2 to 2.5 years. And on average, patients saw 3.7 providers before they were diagnosed. So we've cut the time almost in half. That's good. So we're trending better. But similar studies for something like rheumatoid arthritis, they're all under 1 year. So that's where we should be with fibromyalgia. It should take somebody less than 1 year from time of symptoms to diagnosis. That's what needs to be. That is very clearly not what's happening, because in this survey, so I asked people, how long did it take from time of symptoms starting to when you got your fibromyalgia diagnosis? Under 1 year, only 7% of people said yeah. So a very small amount of people were diagnosed under 1 year. And that's really a shame. More people were in the 1 to 3 years range, and that's similar to what this 2010 study showed. So about 40% of respondents said it took them between 1 and 3 years to be diagnosed. Another 40% said it took them greater than 5 years to be diagnosed. And then oddly, only 7% of people were in the 3 to 5 year range. So the takeaway is we're nowhere near where we should be, which is under 1 year, but things are improved because for the bulk of folks, it at least was under 3 years. So progress, but still really disappointing. So because we don't have, or we haven't had a lab test, up until 1990, doctors were just making it up as they went along. And this is where so many doctors in their training before 1990 were like, fibromyalgia doesn't exist, hysterical woman's disease, etc. I mean, it was just totally not taken seriously. In 1990, a group of rheumatologists, including one of my mentors, Rob Bennett, who was up at OHSU for many years, a group of rheumatologists gathered and they worked together to find a consensus on what could we use to diagnose fibromyalgia. Interestingly, this was not designed for clinical use, meaning for doctors to use in practice. It was designed for research because they wanted to say, like, how can we know who to include in our studies so that we know these people have fibromyalgia. But because it was all we had, it's what we started using really for clinical practice. And so this is where the tender point diagram comes in. This is in chapter 2 of the FibroManual, which is about diagnosing fibromyalgia. These are the 18 tender points used to diagnose fibromyalgia. And what that 1990 criteria said was you needed to have widespread pain for three months or more, and you needed to be tender in 11 of those 18 points. And tender really means pain upon pressure that normally would not cause pain. So somebody without fibromyalgia, you press on, their tender points. One of them is like kind of right in there. People without fibromyalgia, they're like, why are you pressing me there? But it's not painful with fibromyalgia. And I remember when the chiropractor diagnosed me, he like pressed there and I was like, oh my God. But I thought everybody hurt right there. Like it didn't register to me. So enough of those tender points, widespread pain, 3 months or more, you've got a diagnosis of fibromyalgia. And that was it. That's what we had to go on for 20 years. 20 years until in 2010, this same group of rheumatologists, which I will say was mostly white men. I think there was like maybe one woman on this consensus team, but that's a different story. And what they said was, hey, we're recognizing a few things. One, a lot of doctors in clinical practice are using the tender point exam, but they don't know how to do it. And so fibromyalgia is being underdiagnosed because providers either don't know how to do the tender point exam or feel uncomfortable doing it, so they kind of avoid doing it. It was designed for women. So when you compare the tender point exam of women to men, it's very different. Men don't tend to be tender in those same spots. So what using that diagnostic criteria was doing was excluding a lot of men with fibromyalgia. So they recognized that, and then they recognized that fibromyalgia is more than pain. And they said, hey, we also have to address the fatigue, the brain fog component, the sleep disruption. So we got to expand our diagnosis. So what they did is they dropped the tender point exam completely. They kept the more than 3 months widespread pain. And then they added that you needed to have some of the symptoms of either fatigue, brain fog, sleep disruption. And then they said depression and abdominal pain or headaches. So you needed to have some of those 6 symptoms. So brain fog, fatigue, interrupted sleep, depression, abdominal pain, or headaches. And they have this kind of numerical score that you have to have. You have to have enough of those along with the widespread pain for 3 months. Then you've got a diagnosis of fibromyalgia. Okay, 2010, better, right? Some of us, like myself, I still use the tender point exam because I think it's very informative, so I can understand where a patient is hurting and where we might need to direct our treatment. But I use it with a grain of salt. I don't use it as the sole diagnostic criteria, I do incorporate these newer 2010 guidelines, which were then updated and kind of refined in 2016. And that's roughly where we have been. Newer groups, like there's a 2019 group that was, I think it was like the American Society for Pain. They were a group of pain doctors who kind of tried to refine and develop different criteria. So now that's just all kind of, but roughly the same kind of thing. So, better. We've got some improvement. And that does mean that people are paying attention and trying to figure out ways to use it. And the really good thing about the new updated 2010 and then 2016 American College of Rheumatology diagnosis is that it was designed for both research and clinical practice. So it was actually designed to be used in practice, and it really has increased the rate of how many people with fibromyalgia are being diagnosed. Hello, Georgia. Vito from Georgia. Because it's something that a doctor can do. Like they actually can kind of hand this like a survey type thing. They can score it, and it's not perfect, but it's much better. And we are seeing higher rates of people being diagnosed. However, the gold standard, what we really need is a lab test, either a blood test, a diagnostic test, an imaging test, something that will consistently differentiate people with fibromyalgia from people that don't have fibromyalgia. And this is where, if you have been paying attention to the fibromyalgia world, you might say like, but what about that FMA test? So it's like capital F, capital M / A test. And that came out in like 2013, 2014. And it was billed as a definitive diagnostic test for fibromyalgia. And I remember thinking like, wow, that's amazing. This is going to like really change things. But it really hasn't, and it really hasn't taken off. And I will kind of tell you why I think that is. So what the test is, it is a blood test. And what they do is they take certain white blood cells out of somebody with fibromyalgia and compare them to healthy controls. And then they stimulate them, they kind of aggravate the white blood cells, and they see what chemicals the white blood cells secrete. And so it's basically a marker of like how the immune system is responding in this one particular way. And what they found is that they thought that the fibromyalgia blood cells were going to like overreact, but in fact, they really underreacted. It's like the white blood cells, even our white blood cells are burned out, and they just kind of didn't secrete very much at all. Whereas the healthy white blood cells were going crazy when they were, because the normal response to these aggravating factors should be a robust immune response. So that was kind of the thought, like, okay, great, there's like an immune system difference. And this might be where things went awry. They went directly to market. They went directly to selling this test to consumers. They priced it at over $1,000. It was not covered by insurance. And they didn't have it go through that process before they sent it to market. They didn't have it go through the process where other researchers, so not the people that have a financial interest in it, but other researchers do what's called validation. So they try the test too, and they say, aha, yes, it does work like that. Aha, yes, let's see. And then it kind of would be included in, this is how like things like the rheumatoid factor for rheumatoid arthritis came to fruition. But they went directly to market. And so that was kind of a mistake. And I remember patients telling me like, oh my God, like $1,000, but I think I need to get this because then it'll help my disability case. And I was like, I don't think the Social Security judges are going to know what the heck to do with that. And it's not well established. And so we've kind of been in this like, what do we do with it? In 2015, in an effort to kind of improve this, the people that created this test, and there are researchers, what they did is instead of comparing people like healthy people to fibromyalgia, they did both healthy people and those with rheumatoid arthritis and lupus, compared them to fibromyalgia. And unfortunately, what they found was it didn't work as well to differentiate people with fibromyalgia and rheumatoid arthritis or lupus. And I think, let's see, I wrote it on here. in that 2015 study, they were able to, with this test, correctly identify 93% of people with fibromyalgia compared to healthy controls. So when they looked at people, 93% of people with fibromyalgia, their white blood cells responded like they expected. Only 11% of healthy controls responded in that abnormal way. But around 30% of people with rheumatoid arthritis and lupus responded that same way. So you couldn't tell the difference. And these were people that they specifically looked at and excluded. They said, you can't also have fibromyalgia and rheumatoid arthritis and lupus. So these are people that theoretically don't have fibromyalgia, and you can see it wasn't as good at distinguishing. So maybe that's part of why it fell to the wayside. Just as I kind of finish up here, I was reading in 2019, this American Pain Society, they did this kind of review of all the different ways that people have tried to diagnose fibromyalgia, including the 1990 criteria, 2010. They didn't even mention the FMA test. So as of 2019, it doesn't even get a mention. So I don't know what happened, but it did not seem to prove out in clinical practice. And I don't know, maybe there's behind the scenes things we don't know about, but it's unfortunate because I had kind of hoped maybe that would be how we could get a definitive test. But the last few things I have to say here is, if you have paid attention to the mouse antibody study that I cover in another video in great detail, in that one, you could definitely see there is an immune system abnormality in fibromyalgia that could lead us to a diagnostic test. So in that study, briefly, they gave healthy mice the antibodies derived from people with fibromyalgia, and the mice developed central sensitization and symptoms of fibromyalgia pain. When they did the same thing with healthy people's antibodies, didn't have an effect on the mice. So if we could identify one specific antibody, that could be like a fibromyalgia antibody test, and we could say, yes, you have it, or no, you don't. And that would be exactly what we do, like rheumatoid factor, which we use to diagnose rheumatoid arthritis. It's just an antibody test, but it's a very specific antibody. So if ultimately we can find one specific antibody, that would be amazing. And then the diagnosis, I think we would so quickly get to yes, almost everybody is under that 1 year to diagnosis mark. So that's hopeful. That being said, research takes a long time, and I think it'll be at least 5 years before something comes from that to actual clinical practice, maybe even longer, depending on how things play out. So I think for now, we're still stuck with this kind of muddle of you have to get a diagnosis of fibromyalgia, you have to be able to present the correct pattern of symptoms to a physician. That physician has to have enough knowledge about fibromyalgia to recognize that pattern. They have to be willing to do the workup, and not everyone is. And then they have to do the test. That's my dog. Hold, please. Oh, somebody's at my door. Of course, during a YouTube live. How very live. Fibromyalgia initially was thought to be an inflammatory condition, which is why it was sort of lumped into the rheumatology specialty. But as we kind of were able to see more like neurologic abnormalities and sleep abnormalities in fibromyalgia, and a lot of the typical immune studies like we do are normal in fibromyalgia. So because of that, the rheumatologist kind of said like, hey, it's not really an inflammatory condition. It shouldn't be in our specialty. The primary care doctors should deal with it. It sort of became this orphan disease, right, where nobody really wanted to claim it. But now we can definitively say that the immune system is involved in generating fibromyalgia pain. We can't definitively say what exactly that means, and we can't exactly say, yes, it's an autoimmune, meaning the body attacking itself condition, but absolutely, I think fibromyalgia, uh, it's being looked at with different lens. So that's a very good question. How do I think fibromyalgia should be classified? Hmm. I mean, I guess it does technically probably fit the best into rheumatology, but I think rheumatologists are really of physicians, they probably have the most negative view of fibromyalgia patients. So I don't I'd rather another specialty manage things. There's not really, I think if there was like a myofascial specialty, that would be the best, but there's not. So neurology, sleep doctors, I mean, any of those could kind of do a better job, but ultimately because it affects so many systems, it ends up being managed by primary care doctors. And I think that's okay. There are some conditions that pretty much primary care doctors can manage. Like most patients with just kind of straightforward diabetes, they don't need a specialist, just managed with their primary care doctor. High blood pressure, that's another thing. High cholesterol, don't typically need to see a specialist. Primary care doctors got that. It's kind of their bread and butter. So because fibromyalgia is kind of a holistic disease affecting so many body systems, maybe it kind of makes sense for primary care doctors to take care of it. But they don't have much time. And in our current healthcare system, you know, there's there's not really a good field. I mean, I don't know. That's actually a really good question. Um, oh, okay. Rob, you're asking a very controversial question. So he asks, do I think fibromyalgia is progressive? So you have to first define what you mean by progressive. And how doctors define progressive is something like degenerative, meaning gets worse and worse over time to the point that ultimately the disease becomes so severe that it either kills you or creates a significant disability. Good example would be something like Alzheimer's. We look at Alzheimer's dementia, we know that it's going to slowly get worse with time, and ultimately the outcome is going to be ultimately death from some reason related to the Alzheimer's. That's what doctors think about when they say progressive. They mean degenerative. When patients think about it, it's a little bit different. And they ask, are my symptoms going to get worse over time with fibromyalgia? And the answer typically is yes, but not necessarily due to fibromyalgia, due to the fact that as you're going along, you're also getting older. So our body is kind of breaking down, right? So we have more areas of pain. I mean, people in their 50s, even without fibromyalgia, have more aches and pains than a 20-year-old, right? So if you are going along with fibromyalgia and for a while you're able to manage things with exercise, but then you start getting bad hip arthritis, you're not able to exercise, then you have to have surgery, you never quite feel the same, then you've got more low back pain. So it's like as we get older, I think our body breaking down can make the symptoms of fibromyalgia worse, just like the symptoms of living get worse as you get older. But the caveat to that is we also learn more ways to deal with our symptoms. So we become wiser, I would say. So what I typically see is it's sort of a flat line for most folks. Now that's not the same for everybody. And if somebody, ends up having a second illness that causes pain, somebody with fibromyalgia who then develops, rheumatoid arthritis as an example, they're going to have worse symptoms. But just in general, I think it's typically a flat line. So I don't consider it a progressive illness from a medical standpoint, but I have found from experience when I talk about that, it can be kind of controversial, and some fibromyalgia patients sort of find it like offensive, we're sort of trying to take away the severity of how somebody is dealing with things. And I don't mean to do that at all. Everybody's journey is different, but not progressive from a typical medical perspective. So, got a few more minutes. And yes, I totally agree. Another comment is it's a problem if you run from doctor to doctor and they don't treat the whole person. Absolutely. Part of why it can take so long for fibromyalgia patients to be diagnosed is maybe their biggest symptoms come from irritable bowel syndrome. So they start seeing a GI doctor, but then they also start having headaches. So then they're seeing a neurologist for their headaches. But then they're also having low back pain. So then they start seeing, a pain specialist or sports medicine doc or, or an orthopedist, right? Who's kind of, oh, we got to operate or whatever. So absolutely, I think that is why the primary care doctor who's kind of looking at the whole person would probably be the best to sort of manage fibromyalgia as a whole with then sort of just when needed asking for help from specialties. So one of the questions is about EWAT system, and I don't actually know what that is. Is it like a hyperbaric kind of thing? So give me more information. I can answer that. And I have not heard about Dr. Guillermo. I don't know how to say it. Says 80% of all fibromyalgia sufferers are non-secretors, regardless of blood type. I don't know what non-secretors is referring to. I have not heard of that either. But if you guys can give me some more information, I could answer that. Exercise with oxygen. So an exercise with oxygen system is what he's asking about, or they're asking about. Yes, absolutely. Hyperbaric oxygen therapy, where you have oxygen pressed into your system with high pressures, has been shown to be helpful in fibromyalgia. I'm actually going to do a video about that pretty soon. So I would imagine anything that you can get more blood flow, more oxygen, particularly to your brain, actually, it can really help with fog and fatigue a lot. And then let's see, the other question here was who treats fascia issues? Well, a lot of doctors don't even really understand the contribution of fascia to pain. So there's not really anybody, I would say kind of sports doctors, orthopedic doctors, they're at least aware. Most doctors think fascia is relatively inert and doesn't cause pain. My whole theory about fibromyalgia is that it's our painful fascia that is generating the pain. So I would say myofascial release therapists are probably who treat it the best. Maybe we need, here's my idea, and I will end with this. We need a new medical specialty where people, physicians can get trained to just treat fibromyalgia, learn all of the things, kind of do what I did. I made my own specialty, right? Understand myofascial issues, sleep issues, neurologic issues, immune system issues, hormone, GI stuff. I think that would be awesome. Right now, it's a specialty of like maybe 3 of us, so we need more. And hello, somebody's watching from Brisbane. That's lovely, lovely. Okay. So here, I knew somebody was going to ask about Lyme disease, so I will end with this. So, is fibro linked to Lyme disease? So, very controversial question. So, Lyme disease is recognized as a stressor that can trigger the development of fibromyalgia. So, a lot of people with Lyme disease develop fibromyalgia. Is all fibromyalgia caused by Lyme disease? No. And there are some alternative providers out there that feel like, hey, Lyme disease is behind like every case of fibromyalgia. And then there's people out there that say chronic Lyme disease doesn't even exist, so it's a really wide dichotomy. But I would say Lyme disease is recognized as one of those things that can trigger that prolonged hyperactive stress response that generates all the symptoms of fibromyalgia. So if you have both Lyme and fibromyalgia, you have to address both. Okay, so I'm so glad that people joined from the UK, from Brazil. Oh my gosh, yes. Desiree coming in with a question at the end here. So Desiree, said one question from the last one is fibromyalgia passed down through generations? So, oh, Denmark, wow, that's so great, so international. So, sadly, the answer is somewhat yes. So, just like somebody with diabetes, their child is more likely to develop diabetes. It doesn't mean they're going to. It's not 100% you're going to, but it is thought to contribute. One of the big studies that was done on this found that a close relative, so somebody who's like a parent or sibling or child of somebody with fibromyalgia. So my relatives, blood relatives, have an 8 times higher likelihood of having fibromyalgia. So there is a genetic contribution. But I was just reading today, actually, what they're finding is just like in most illnesses, 50% comes from genetics, 50% comes from that, and 50% from environment. So let's say you're somebody who's predisposed to fibromyalgia, but you never have that triggering event, car accident, Lyme disease, whatever, you're not going to develop it. So I also have hopes not to pass it on to my child. Sadly, I will say they are having some symptoms. They're in their teen years. They're having some symptoms, but I'm getting him right away into myofascial release. So if you have any kid, teenager, anybody, early diagnosis of fibromyalgia, the earlier you can get them into myofascial release, the better I have seen that outcome be. So that at least can be hopeful, along with maybe the antibody studies. Maybe we will have a lot better treatments, maybe even a cure in the next decade or so. So that's what kind of keeps me going.